I do is I send a greeting or I send a bouquet to them. Bouquet to them. Done so.
I won't believe. Now leading practitioner Dr. Mohan, including other people, they used to attend. At that time, it was very popular. They were saying the
early stage of the practice just
improving. There are few points there. Thank you, Kailash. Now third speaker.
So the next, I'm talking about the next speaker, Dr. Mohan MD, General Medicine. He is the Managing Director and Consultant Physician, MK Nursing Home, Tandayarpet. In fact, MK Nursing Home is Dr. M. Krishnamurthy. In fact, Dr. Mohan is his son. This news I got only now because I had worked in Tandayarpet area. I was in Parliament Transport Corporation as medical officer. So I used to send a lot of cases to MK Nursing Home. So I met several times Dr. Krishnamurthy. In fact, now only I came to know about this son. So I'm really happy about that. Now, he is currently elected President IMA North Chennai. He has facilitated Department of Diabetology in Annamalai University since 2005 and MGR University since 2013. He has conducted more than 10 diabetology conferences in Chennai from 2006 to 2018. He is a speaker in various forums, IMA, RSSDA, Diasicom, API, etc. He has chaired various international and national conferences. He was person in charge for 2 drug trials and published data for 2 nutritional products. He is going to give a talk on things to do by a family physician before admitting a serious patient. Over to Dr. Mohan, please.
Before that, I just around 40 years. In fact, why I selected this topic was many times we get a heart attack patient to a clinic. They'll come to us, but what we should do, something we have to do and do, send it. And that will be very useful for the golden hour also. So that's what he's going to talk. But any of you want credit hours for this meeting, please contact who? Dr. Rahul is there. Rahul is there. You can give it to him. He will give the credit hours. So over to you, Dr. Mohan.
At the outset, let me start thanking Dr. Kailash sir and Impai for this wonderful opportunity. Diabetology teaching is a great change. Today I've been lucky enough, like sepsis pati thank you very much, sir. And I have been part of your Impai group for the past 20 years. MBBS board first after MBBS, my first degree was from your class. Thank you very much for this opportunity. Next, please. The common emergencies in general practice could be trauma, cardiac emergencies, respiratory emergencies, neurological emergencies, sepsis, GA emergencies, and psychiatric or poisoning. These are the same. I understand the GP level or admission treatment general practice role reference, please. The initial assessment and starting of treatment is a must in all these things. Initial assessment must now, you would know the patient better than in hospital to whom they go because they have been with you for a longer time. That's not an initial assessment, that's one plus point. Another plus point is current guidelines and mandatory by law also that you should not just refer a patient. Even in a thing, somebody comes with emergency, first aid should be given, then only they should be sent out. So we feeling that chest pain is another thing is not enough. There are certain things you need to do, otherwise by law you are answerable to them. Like for example, last week a child came with after child was left in the crutch. They have given a banana, it went inside. Resuscitate it was brought, it was blue and it was brought. Then it was sent to Apollo. They put a prong, they could take it out. we don't have this because we don't see pediatric. But then they had to lodge a complaint. The child died before.
Many a time we refer the case fast because since we don't have any facility, நீங்க செத்து போன ப்ராப்ளம்னு நினைச்சிரோம். அதுல தான் அனுப்புறோம். Nicely without doing anything fast.
Despite doing something good and then declaring it or sending it to Apollo for declaration, they put the thing. Then police came and said, "Ellam paniranga penance," so they left off. But then there's always a blame game which is occurring. So make sure at least basis is given. Something needs to be done before we do that. Otherwise, by rule, you can get into trouble. Next, please. Next, please. First scenario we'll see is trauma. Whenever you see a trauma, let it be on the road or in the clinic, few things need to be done. A primary survey. Next, please. Primary survey would include ABC, the airway, breathing and ventilation, circulation, and stabilization of the spine, or three things in any trauma you need to do. The airway, if not, at least the best they will do in cricotomy and all. We've heard stories about it. Here we don't do all that. At least make sure that they are in the thing, the head up, so that their airway blocking is much lesser. Let us say instead of a trauma, somebody's got a seizure. அதில் அவங்களோட செக்ரேஷன் சோக் பண்ணாதமே சைட்லியாக திருப்பி படுக்க வச்சு அதை சொல்லியாவது அனுப்புங்க. Because by the time they reach the thing they say that we have not done it. Secondary would be like any possible, let us say for example the same thing, had it been a pill or something and the child you put a tap in the back and it comes out. That is a necessary step you need to do. Another in a trauma the airway assessment tell them so that the patient doesn't choke at all before they reach the thing. And secondary survey, like for example or bleeding something which should correct, you should apply the thing at least so torrent even if you are not in the thing to switch it up, or basic occlusion for the bleed should be there. Nowadays better things are available like glue which is available, or steri strip is available. At least as a portrait some hemostasis will be there, otherwise you can bleed to death. And there will always be everybody is ready to badmouth about their colleagues, so so this sort of thing. The other thing is like whenever let us say bone is stretched or injured, make sure it is put in anatomical position, tell them not to move it and go, so that the outcome is better. இதெல்லாம் பண்ணிட்டா கூட சார் அவர் எவ்வளோ ட்ரை பண்ணார் சார், அவர் பண்ணார் சார் ஒரு வேர்ட் சொன்னாலே the other physician stopped bad mouthing about us. Next please. And before you have to triage the patient for the complication. If necessary, resuscitate, then send. Next please. Cardiac emergencies. The commonest cardiac emergencies that generally will get is one is breathlessness, cardiac breathlessness. The other would be a heart attack or a chest pain, angina, which could be a heart attack. One of them is palpitation. This is one of the commonest thing which will come to the GP. Most of the time, nowadays they go directly to the cardiologist. Bedside also, where it is not available, first call will be the same. And the moon scenario very commonly we see. In terms of a myocardial infarction, if you think it is the thing, if you have ECG, you can take it. If not, nearby it is there, you can take it. That could be confirmatory. But remember, in a classical chest pain is rarely on the chest. It is usually radiating to the neck or to the arm. Blood pressure would be slightly higher or could be lower in terms of an MI. But if you think it is a classical thing, 30 to 40% of ECGs can be normal. So make sure before you the thing, just because ECG is normal, don't give ultra high hopes. If you think it is in this thing, send them up. I will to do a drop and follow it up. Or if you think you can't rate it, at least tell them it needs to be followed up. You can't leave it alone. So necessarily, if you are not able to take an ECG, but you still feel there is such a thing. Pulse oximeter almost all of us have nowadays because that's become the routine. Pulse easier everywhere that's been the routine. So look for signs of hypoxia. Then actually you can give them oxygen before sending. One oxygenation. And loading dose, what they call as a loading dose. 335 milligram of soluble aspirin. You get the 300 milligram tablet, 300 milligrams of soluble aspirin, clopidogrel, and and statin 80 milligram can be given together. Gastritis, but ஒரே ஒரு இது என்னன்னா chest pain or alternate could be gastritis. Aspirin can cause a bleed. So if you are not sure, at least you can give clopidogrel and the thing also if you are suspecting gastritis, because you don't want to induce a bleed into the gut. Other தவிர if pain is there, nitroglycerin sublingual can be given if blood pressure is alright. If blood pressure is too low, nitroglycerin can cause further dip in the blood pressure. Take this thing. Previously, the initial beta blocker was included. Now it is no more included. Don't give the thing even if the BP is very high. Even in a crisis, we don't use beta blocker as the first line unless it's IV beta blocker. We don't use it as the first line. Pain morphine can be given if you have it. In a pain reduced such knowledge, in general it is better. Ask him to take deep breaths so that the oxygenation keeps going better. These are minimal things we can do. Arrhythmias பொறுத்த வரைக்கும், if you have generally you know a GP setup and சொல்லி இதெல்லாம் நம்ம western textbookல பார்த்தா and what you call shop கொடுக்கிறது cardiovascular is included. So when you look at textbooks, they always say you should have a cardiovascular possibility. You look for arrhythmia because time is lost. You are supposed to cardiovascular, but number setup that is not a basic which is available. So if it is there, please try to reverse it and then send it. And the thing which spontaneously reverse or reverse with a single cardioversion usually does well. You don't need admission also in such patients. அதுக்கப்புறம் அவங்க EPS study பண்ணி அது சரி பண்றது அது வேற விஷயம். But then you have saved the patient, which is very much necessary. இது பொறுத்த வரைக்கும் and other agents எல்லாம் விட amiodarone is the easiest choice. Hypotension கம்மி ஆகும். Diltiazem and other IV this thing for palpitation can cause an hypotensive crisis, and all antiarrhythmics are pro-arrhythmics, and now you can have the thing. Of the lot, IV amiodarone is the easiest to give with a very good outcome. Next. Cardiac arrest, yes, all of us are supposed to know the basics of BFSL, that is basic life support should be done. We are supposed to try to intubation illana idhula pandra madiri mouth to mouth respiration and number of thumbs per second is something we all need to do if we find the thing. It is mandatory, not an thing. Next please. Okay. Next please. Right. The other things which can be seen are pneumothorax, pulmonary embolism, pulmonary edema, and the so-called heart failure. Pneumothorax unless somebody there's not much we can do in a normal clinic. So those the things are not a problem. But in terms of pulmonary edema, if blood pressure is good, an initial dose of IV Lasix is very much useful because it offloads the system. So it gives them time to read the cell. So that is the basic minimum we need to do for the thing. Next please. Next please. Okay. The next commonest cause why they come to the thing is breathlessness. Breathlessness, moderate or mild breathlessness. ஒரே விஷயம் என்னன்னா நம்ம கார்டியக்கா இல்ல ரெஸ்பிரேட்டரியான வித்தியாசம் கண்டுபிடிச்சிக்கணும். Because cardiac, the typical old teaching was like you look at the chest previous history of allergy irundadna, history of asthma irundadna, a person who's had cough or cold for some time, those are called pulmonary. Wheeze more than crackles, pulmonary. COPD la crackles irukkalam, but it will be generalized. The so-called pink puffer with a huge with a large area of lung, bloated lung, are all COPDs. That's what we used to learn. And on the other side, basal crepitation if blood pressure is too low or too high, previously no history, sudden onset, orthopnea then cardiac and solitary we used to differentiate. But now that is not the thing. What they say is that and dyspnea discrimination index is what they talk about. Dyspnea discrimination index percentage are parameters proposed for reliable differentiating dyspnea of cardiac and respiratory origin are derived from PFR and PFR percentage. That is, அது எப்படி இது பண்றாங்கன்னா PFR and partial pressure of oxygen SpO2 divided by 100. So product of PFR into the partial pressure of oxygen divided by 100. Usually it's around between 5.4 to 8.3. Anything lower than that, it is usually, it means that if it is a pulmonary, anything higher than that is cardiac what says. But otherwise, like most people, in fact, like today when we were talking about sepsis, what they are saying is that the focus is the thing in the hand. Number stethoscope, they have ultrasound machine which is coming up as a thing, where you can measure the thing. So if you can measure, look for B lines, look for the JVP, the thing, that will be the thing which is going to come over time. That's how it's going to show.
When the patient is in crisis like cardiac or respiratory, PFR cannot be done.
I was about to say that. I don't think they'll be in a position to do PFR. So doing this is going to be
Clinically only best. Basal Krebs.
Yes.
Initial origin.
Yes. Next please. So acute asthma, I know sir would be better at it, but then for completion sake, acute asthma exacerbation, can we go back? If you think it is cardiac, two things need to be done. If the blood pressure is very high, hypertension causing congestive cardiac failure, there you are supposed to give an ACE or ARB as a first line drug before you send them. By using an IV Lasix of 40 milligram itself can also cause this. If the BP is moderate and you still feel very comfortable doing or sure that it's cardiac, 20 milligram, half a dose of IV furosemide can be given and sent. Even in renal patients, that can be done without much of a real side effect. We can get away with it, so you need to send with that. If blood pressure is very high, first ARB, other CCB can be given and we can send. Usual time where it takes for any of this things, the IV either to act is from 8 to 20 minutes to solve. So, you are waiting for the ambulance and it comes, it takes around 20 minutes. First dose, you are not the thing, hypertension is there, then you can give an CCB and other thing and send them.
Just in the first call for the ambulance and do all these.
And then do all this. Next please. Yeah. As far as asthma, the thing is that the basic stay of the thing is beta-2 agonist as a nebulized solution would be the first thing. Sometimes, you need to again COPD asthma, and come back to it. If you think it is asthma, there is the thing, initially or dose of steroid IV lot of this thing has gone through. They say like there's not much of a difference between methylprednisolone, dexamethasone, and unless you are sure, do not give because you can miss pneumonias. So unless you are sure of the asthma, do not give anything. Because asthma, the mainstay of treatment is in steroid versus the thing. So some people are suggesting that you can give a single nebulized corticosteroid, which is not be a problem. That's a
Beta-2 inhalers is a must.
Beta-2 inhalers is a must, but a single nebulized corticosteroid add even in it doesn't matter.
Steroid inhalers are available. Inhalations are available.
That a single dose can be given.
But oxygen
IVF
is very important.
Oxygen is important. Oxygen given nebulizers are throughout the world, sir. Only here we have just nebulization. Intravenous treatment include magnesium sulfate as a bronchodilator could be a thing because it's much easier to use.
Nowadays not.
But we don't give because nebulizer we don't need to use that. Next please. The ephedrine subcutaneous we almost the same. Aminophylline is better avoided because of the cardiac toxicity. No more delphinine or aminophylline IV to be given. There is no more. You can even give half dose of multiple nebulization instead of using any of them.
But nothing like epinephrine in acute asthma.
Acute.
Amazing.
Amazing. But if you have
ICU, tachycardia.
Listen, but I think we should take.
I remember those days, every ICU daily.
COPD is a difference. They say like COPD Asthma, why is that difference we need to look at? The COPD is driven by infections, multiple recurrent infections. Asthma, it is more of a allergic lung. So, allergy or is there, there you have, let's say, corticosteroids are a mainstay. In COPD, it's not necessary at all. But whereas COPD, with your nebulization, ipratropium madri or an ileal muscarinic receptor, the action is better. Both mucolytically as well as relaxation is much better. Next, please. Neurological things which are missing. The commonest was the stroke. First presentation of stroke. What they say is that, okay, stroke there is only one controversy going on. In an infarct, if you think there is going to be an infarct, and if you think it is a large burden of infarct would be there, the so-called embolus, then within 4 hours ventricular we can lyse panni, அதை normalize பண்ணலாம்ங்கிறது இருக்கிறதுனால as early as possible ask them to go for a before meeting the neurologist without ask them to அதனால stroke seizure அது மாதிரி வேற எதுவும் வரலன்னா ask them to directly go get the MRI, ring them up, find out what it is, refer to a place where you can put up the thing, so that the time is very very good.
The problem is to find out whether it's ischemic episode or hemorrhagic stroke.
Sir, அதனால தான் நம்ம அது எப்படி இருந்தாலும் நம்ம அதை கண்டுபிடிக்க முடியாது. சீஷர் இல்லாத வரைக்கும் முதல்ல எம்ஆர்ஐ பண்ணிட்டு அப்புறம் இது பண்ண சொல்றாங்க. So that the trial time becomes lesser. முன்னாடி the thing was stabilization, then hypertension இருந்தா இது பண்ணிட்டு போக சொல்றாங்க. இப்போ அப்படி இல்லை. First you go get an MRI, come back, மத்தெல்லாம் பண்ணுங்க, அதுக்குள்ள ரிசல்ட் வரும். வேணா thrombolysis பண்ணா இல்ல இது பண்ணலாம். ஏன்னா 4 hours தான் the window period for thrombolysis is less than 4.5 hours. So earlier the better என்றது இப்போதைக்கு. Seizure ஒரு மேஜர் இது. Even status epilepticus is very critical. Seizure பொறுத்த வரைக்கும் usually, so obviously and another most of them post-ictal state they may not be able to the thing, they possibly even if you are referring 2-3 things need to be the thing. That is the time tongue can fall back, they can choke. So make sure they are put on one side. If possible, keep something so that the tongue doesn't fall back, number 1. Number 2, pad that the thing so that they don't hurt themselves because of seizure. Very common, shoulder dislocation, seizure is a very side effects to come. So, take care. Seizure, if possible, you can give the current drugs like anti-epileptics like levocetran are quite safe. So, single IV can be given and sent. Next, please. The truth is, IV diazepam or lorazepam is the drug of choice. But many times, if they go for an respiratory depression, it's very difficult. So, they know what they are saying is that the levocetran seems to be as effective as the thing. So, first line as a put it, then you can. Yes, epsilon or something given in the hospital setting is fine. But in the normal setting of portfolio, the director put it which is acceptable. Status was yes, diazepam is the thing where you have to get a written consent and say that to make, if you, by the time you reach, you may not, the patient may not be available, you have to say. Single episode, they say, first episode, single, no real reason for it, it stops, they say don't treat anything. That was prevent பண்ணி அனுப்பலாம், அடுத்தது வழியில வந்துருமானா prevent பண்ணி அனுப்பாதீங்க. Don't do anything, it could be because of bleed, could be because of hypoglycemia, so many other things can be there. So single episode, don't treat. But known is மாத்திரை விட்டதனால வந்தது, இல்ல known is recurrence, then and levocetran IV should be given and sent over 20 minutes, 15 minutes and then sent to the hospital.
Levocetran clinically இருக்கவே இருக்காது சார், அதான் பெரிய ப்ராப்ளம்.
But easy correct is sir, very very easy.
அது போய் வாங்கிட்டு வரதுக்கு 10-15 நிமிஷம் ஆகும்.
But by that time patient would go somewhere else. Next. Okay, this is how it goes. See, stabilize the patient, make sure that ABC is looked into. If things are alright, then you can access பண்ணலாம். If not, the refractory status epilepticus ஒரே வழி intubate பண்ணி ICU ல இது பண்றதுதான். அதுலயும் ICU தான் அவங்க diazepam கொடுக்க சொல்றாங்க. So we need not necessarily give it, we have a right to refer that. Next please. Okay, sepsis, the problem is they come with disorientation. Many a time செப்சிஸ்ங்கிறதுக்கு வந்து நம்ம 3 இதுதான் பார்க்கணும். ஒன்று டாக்கிகார்டியா இருக்கா, ஓரியன்டேஷன் எப்படி இருக்கு, யூரினேஷன் அமௌண்ட் எப்படி இருக்கு. ஸோ ஹைப்போவோலிமியா இருக்குன்னா தட் நீட்ஸ் டு பி கரெக்டட் அஸ் ஃபர்ஸ்ட் பாயிண்ட். அது நிறைய இது இருக்கு, கிறிஸ்டலாய்டு அப்பலாய்டு அதெல்லாம் இருக்கு. அப்படி இல்லைன்னா கூட அட்லீஸ்ட் 300 ml ஆஃப் ஃப்ளூயிட்ஸ். ஏன்னா கன்ஜஸ்டிவ் கார்டியக் ஃபெயிலியர் ஏதாவது இருந்ததுன்னா which will precipitate event. இதனால மினிமம் 300 ml ஆஃப் ஃப்ளூயிட். See, around 30 ml per kg per hour. That is the thing. So 60 kg na 60 is around 180 ml to 300 ml can be given the first the thing. Adula வந்து minimum 200 ml can be given and you can send it. Now so that the perfusion doesn't fall down before they reach. Only antibiotic selection na வந்து it is separated. It's not for us. Two causes of sepsis we should remember. இந்த இதுக்கு வந்து இதுக்கு நடுவில் ஹைப்போகிளைசிமியா the cause. I mean sepsis ஓட கூட வரக்கூடிய cause for the disorientation in sepsis we should remember. Hypoglycemia இருந்ததுன்னா if a person is the thing, better to give IV glucose. 25% dextrose வந்து ஒரு ஆம்பிள் கொடுத்தா போதும். We need not keep repeating because it can take up till 20 minutes to 1 hour before they totally recover. Okay, நம்ம ஜெனரலா நம்ம பக்கத்து கொடுத்த அடுத்த செகண்ட் the other thing, but don't overload. நிறைய பேர் வந்து 5 minutes 10 minutes they don't grow, they wait, it's not better, give one more doesn't help. So ஒரு ஆம்பிள் கொடுத்து அதுக்கப்புறம் we can just with the 5% dextrose the thing. If not after 20 minutes 15 minutes உங்களுக்கு recover இல்லைன்னா one more ampoule and never more than that. Then you should look for other causes. Don't just keep treating other thing. அப்படின்னா அவங்களுக்கு வந்து மற்ற இது கொடுக்கலாம், கார்டியோஸ்டீராய்டு கொடுக்கலாம், அதர் தெராபிஸ் தானே தவிர டோன்ட் ஓவர்லோட் அபவுட் தட். ரெண்டாவது வந்து ஹைப்பர்கிளைசிமிக்லயும் வந்து இந்த மாதிரி எமர்ஜென்சி கேன் கம். அதுலேயும் வந்து ஃப்ளூயிட் இஸ் த ஃபர்ஸ்ட் டைம். ஹைப்பர்கிளைசிமியா அதுலேயும் டைரக்ட் கீட்டோசிஸா இருந்தாலும் ஹைப்பராஸ்மோலாரா இருந்தாலும் ஃபர்ஸ்ட் ஸ்டெப்ல வந்து 1 hour ஃப்ளூயிட் தான் கொடுக்க போறீங்க. ஸோ ஸ்டார்ட் த ஃப்ளூயிட் யூ கேன் சென்ட் தம். ஏன்னா அந்த சுகர் கரெக்ஷன் should not be our main goal there. Again it should be. So these two can mimic sepsis. So the fluid resuscitation in sepsis is something which we have to do to start with, and then you can listen for the thing. Rare நீங்க வந்து epinephrine start பண்ண வேண்டியிருக்கும் if the BP is too low, so that by the time they reach the hospital they don't they shouldn't lose them. Rare that can be started. But then that again that dental fluid there's so much of the thing. But you start with the fluid and send. That would be enough. Next please. Okay. The either பொறுத்த வரைக்கும் gastrointestinal bleed பொறுத்த வரைக்கும் previous generation putting tube was the norm. No, we don't disturb. Generally we given emetinic to stop, not emetinic, and like one of the bleeding நிறுத்தத்துக்கு இது கொடுத்துட்டு then you just refer. Lot of people give a PPA. They say like PPA can also cause other trouble. So initially என்னன்னு assess பண்ணாம PPA கொடுக்க வேண்டாம்ங்கிறதுக்கு there are various routine நம்ம ஊர்ல வந்து ஒரு gastrointestinal bleed எதுவா இருந்தாலும் ஒரு PPA கொடுத்துறோம். Now they say don't just give a PPA without doing the cause. There are and other thing is like perforated ulcer, all those things guarding ஏதாவது இருந்ததுன்னா பெயினுக்கு மட்டும் ட்ரீட் பண்ணிட்டு we can send. Other than that gastrointestinal emergencies ஒன்றும் பண்றதுக்கு இல்லை except in cholecystitis. Next please. Cholecystitisல மட்டும் pain management, ஏன்னா pain shock can occur with cholecystitis. The pain is so high. In that pain management is a must. You have to take care of the pain and then send them because of the pain shock people will die. Next.
என்ன painkiller? Morphine.
Morphine is the safest drug.
Morphine is not available.
Not available, sir.
No, you have to keep it in your clinic. Only a doctor can prescribe for a morphine.
இல்ல அது மட்டும் இல்ல, the NAB drive வந்ததுக்கு அப்புறம் they say everybody should start owning a license. License they are charging around 2 lakhs to give a license. So it's becoming
the morphine you can apply and take it. I have a pharmacy, so no problem for me. But if you don't have pharmacy,
இல்ல சார் pharmacy-க்கு இந்த license கொடுக்க மாட்டேங்கிறாங்க. Narcotic license they don't give it. It's become very costly.
Morphine related
Tramadol is safer compared to this thing. Diclofenac is no more safer. Another tramadol would be the safest. They say Itidal is quite safe comparatively. IV Interlac is available, just build it.
Cox 2 in it.
Yes, sir. It is a modified like Pramaro. Poisoning less, if at all the thing first is there, you should try to give activated charcoal. Wash, do not give a wash because wash can dilute and make it more absorbable. So give only activated charcoal. Carbon monoxide poisoning remove the exposure, 100% oxygen and send them to the nearest thing. Paracetamol poisoning, but it is later. So activated charcoal put the next please. OP and all is more of the thing we do not be worried about. Aspirin poisoning, of course, that PPAs are indicated, not useful, but they say it is indicated along with activated charcoal, then send them.
You have activated charcoal in your clinic, is that? Why is it?
Easy available.
Yours is a hospital. Yours is a
Mine is a
hospital.
hospital, yeah, that is
Because the level of intervention in a clinic versus a hospital setup.
very different, very different. No, but then
you're
see,
giving a lot of ER things.
I understand, but the problem is there are certain level of whether we need to do. Like for example, stabilization and post trauma, we are supposed to do. Like the basic triage, airway, like by rule, what they have said by rule, the NMC that it has never occurred. But what they are saying is that
double-edged sword. Like in a nursing home or a mini hospital, you have the personnel, and even if you're NABH certified, you can say they have the roles. But if you did the same by saying it's by law in a clinic, the flip side of it is that you have untrained people doing things.
So many
both
things.
ways you are going to get into trouble. So I think
that's why I said I told that last week we had a child. That's why I said that the hospital we don't see pediatric. Last week a child came where we couldn't take out the banana, it was totally resistant, it was blue. They went somewhere else, somewhere the photo எடுத்துட்டாங்க. I mean, site was that was different. But why didn't you secure the airway first and then the police case came? Then we had to ask them, then they said, okay, I mean, parents also said everything is done with what is happening, but then, as you're saying, it's a double-edged sword. But then by NMC, they said that the government is even promised that they are ready to pay for whatever expenses that is done, and you have to do the first aid and so on. First aid, some of these things become a must. Like, for example, in a seizure, you have to give a single dose of the thing and then becomes a must.
This comes to me. It comes under emergency care. It may not come under first aid. So I think the understanding of what is first aid versus what is emergency care is probably where the confusion is going.
No, but then that will always be there. For example, when hypoglycemia comes, that's an emergency. But anybody is supposed to treat an hypoglycemia. You cannot find that I am unable to do it. And seizure comes. Mouth secure pandrathu is a must. You cannot treat the seizure. But to do that is must. Otherwise you are legally liable for others. And
the worst part is they say for an emergency you should not charge them also. You should not charge for an emergency. You come unprepared with any money, you do your first aid, send it free.
And government is saying that we will reimburse. They have not done anywhere. The basic scenarios we have to say. But at the same time, cardiac thing is the right. There you are not liable because that becomes a treatment. But these things become first aid. Next. Yeah, fine. Thank you, sir.
Yeah,
One doubt I have. When there is an emergency in a flight or in the train, they ask for a doctor whether we may be a pediatrician or some other specialist. How do you manage when you don't have any medications available?
No, they have a full set of medication.
They have.
They have a full set of medication, including the basic injectables they have. But one thing is, again, liability is a problem. There have been instances where doctors have done the thing, then they have been questioned to say that you have not done the proper thing. Liability is a big problem. That's the reason why a lot of people know how claim that doctor treat then we are answerable also. Because many years we don't look at emergency and then you go do something, you get liable.
Pray you don't get an emergency.
One thing in all this where I feel when we be, like you said, you know the patient, you may know the patient better than someone who's walking into an ER. And we are assuming that the ER is all very well manned, that things happen fast. The one thing in sepsis which has been proven to change mortality, only thing is the IV antibiotic. So I think that is something which anyone kind of knows how to do.
No, but the other way around also, what they say is that there is a certain set of antibiotics to be given. Like for example, first call antibiotic in like for example, you will take in terms of urinary tract infection, vancomycin plus or a meropenem is the first call antibiotic.
But even then, it's difficult to give those vancomycin in private practice, clinical practice.
Otherwise, first call antibiotic should be separate. After that, 24 hours, the so-called fast is the thing. And after 24 hours, you are supposed to change the antibiotic. And now, sepsis, hypotension, start IV fluid for the thing, send us. That will be the most ideal thing, because he will not die by the time he reaches. That should be a first call. Selection of antibiotics, you leave it to the ER. அதே மாதிரி cholecystitis ஏதாவது காரணம் இம்பார்ட்டன்ட் இல்ல பெயின் ஷாப் வராம நம்ம இது பண்ணி அனுப்பி விட்டோம்னா we can escape. Now many of the things I said are not possible in outpatient, but then we are supposed to do many of the things. That's the minus point. many of இதை பொறுத்த வரைக்கும் அவங்க வெஸ்டர்ன் இதுல என்னென்ன பேசிக்ஸ் அப்படியே தான் இது பண்றாங்க தவிர நம்ம இந்தியன் தனியாக இது பண்றது இல்லை. So வெஸ்டர்ன் இதுல even a clinic has got a proper nurse and PG பண்றதுக்கு educator and இது
proper nurse கிடையாது.
நம்ம private practice proper nurse கிடையாது. நம்ம வந்து nursing படிக்காம somebody would be there to only office boy is there, office girl or office boy is there.
Assistant.
Okay, thank you, Mohan.
You have done a good job. On behalf of my sister,